Hey, Jim Hoffman here for EMS Office Hours, and this is your Monday Minutes. Today, I just want to quickly go over some indicators of acute chest pain and or acute coronary syndrome, and some things that you can look out for, and not sort of quickly dismiss some symptoms that a patient might have that don't sort of fit into the classic chest pain complaint or MI sort of signs and symptoms. So when you have a patient who's having chest pain, most of the time it's the first thing that's going to lead them to call us to their house, right? When they start getting that chest pain, that's usually the thing that makes them call 911. And patients that have this angina pain, this sudden onset of this pain or discomfort, usually it's brought on by exertion or brought on by some type of a stress. And a lot of times the patient is going to complain of those classic squeezing feeling, this classic tightness feeling, or the pressure. They may be diaphoretic. They might complain of shortness of breath, or difficulty breathing, even nausea and vomiting. Now, a lot of times, a patient might complain of things like feeling their heart's racing, or they're having butterflies in their chest. But the thing to keep in mind, patients don't always have this medical background that we do, right? So, whereas we might not tell somebody that we're having butterflies in our chest, a patient is going to sort of, communicate to us what they can based on their experiences of life and how they've explained things in the past. So to them, telling us they have butterflies in their chest, that their heart's racing, is different than being able to tell us that they're having palpitations, right? So just try to keep that in mind, guys. Don't just sort of, rule it out or say it's not angina or maybe even an MI just because the patient's telling you things like, I just feel different, or maybe they're telling you they're having a funny feeling or something like that, right? They don't know exactly how to describe it. They're not going to tell you it's a 10 on 10 chest pain, or they're feeling like an elephant is sitting on their chest, right? They don't always tell you these types of things that we're going to see in our textbooks. They don't read our textbooks. So just keep that in mind. Don't discount the things that you're saying and maybe, kind of look the other way to a severity of what might actually be going on with the patient. We have to do the entire assessment of a patient, and that includes the EKG and our vital signs, along with a good patient history and what's going on with your individual patient. Now, some things you have to think about is when a patient starts having this progression of the cardiac disease, this progression of the angina, what ends up happening is that eventually this angina is going to become, unstable, and you get that unstable angina patient. And when this happens, usually the patient's going to tell you that there's even a change in the pattern, where normally they might get this pain when they do, significant exertion and it's relieved with nitroglycerin or rest or something like that. Now, maybe the pain started with very little exertion, or maybe even so little exertion they don't even remember doing it, right? And the nitroglycerin is not helping, or maybe medication that they're taking is not helping. In addition to that, the frequency of this pain, the frequency of the episodes are going to be more often, and the length of the episodes, they might tell you that it's been longer than usual. The past couple of times they've had chest pain, it's lasted a little bit longer, right? So think about that when they start telling you that, the pain is not being relieved as it normally does. It's not being relieved when they rest, right? So all things to sort of think about, because what happens is when they've got this going on, and additional complaints happening, like maybe weakness, or they're fainting, or maybe they're dizzy, even confusion, right? This can be the type of thing where the patient's progressing to that unstable MI. The heart is starting to need more and more oxygen. It's not getting enough oxygen, and now you're getting to that acute MI, the myocardial infarction, and even sudden cardiac arrest. So you have to try to be able to identify these patients so that you can treat them appropriately, whether you need to call ALS, or maybe you need to do more advanced EKGs or more advanced medications, and all the things that we are able to do out in the field to get that treatment started so that they can get to the hospital and get that continuing treatment once they get there. So some of the symptoms I want to go over real quick, guys, because I want to just sort of talk about the classic versus atypical, right? You might have patients, normally the classic symptoms are these crushing chest pain, the tightness in the chest, right? Pain in the center of the chest, radiating to their left arm, maybe even on the left side of the chest, radiating down the left arm. And then the atypical type of pain or symptoms they're going to have, or maybe a stabbing pain or a sharp pain. The pain might change if they move, or if you palpate it, the pain might be a little bit different, or even complaints of epigastric pain. But when you think about this, think about the sort of equivalent of angina that you can look for, okay, in addition to, let's say if they have an atypical pain like stabbing pain or it changes with movement, and they have other things going on like diaphoretic, they're cool, they're pale, maybe they have a syncope or near syncopal episodes going on, and maybe they're short of breath, or they're having difficulty in breathing. And also look at the risk factors for your patient. 65 years and older, do they have a known cardiovascular disease? Do they have hypertension? Are they diabetic? All these things for you to sort of piece together and be able to kind of be the little detective and figure out if this is something that is truly angina, unstable angina, or maybe even an MI, and be able to identify it and treat it correctly, right? So, guys, this again, real quick, Monday minutes here, right? Just something that I want you to think about when you're getting these patients with chest pain. Okay, now, just real quick, some chief complaints you'll get a lot of times with patients with chest pain. Again, chest pain or pressure, maybe even indigestion, discomfort in the chest, difficulty breathing, weakness, the fainting or the syncope, palpitations, and that squeezing and the tightness. The signs and symptoms can be, pretty broad with these patients, guys. Chief complaints can be specific, like we're showing you here, or they might be more vague. It's up to us as the clinicians, as the emergency providers, to sort of, filter through a lot of this stuff. Think about other things like their risk factors, like the atypical versus classic, and even the anginal equivalents, to let us know that there is indeed something going on with this patient's heart, and we need to go ahead and treat it aggressively to avoid getting into that acute MI or the even sudden cardiac arrest. Guys, I hope you can use some of these Monday minutes. Again, just a quick little, overview here, and in my hopes that these are the type of things that you'll keep sort of in the front of your mind when you get to your next chest pain patient, and not sort of, blow off signs or symptoms that don't really fit the classic sort of textbook signs and symptoms, and to look at the whole patient, your whole scenario, and everything that's being presented to you and everything that you find upon your exam. Guys, if you can use these minutes, that's great. Be sure to let me know if you have some minutes of your own, something you want me to cover here on Monday Minutes. I'd be more than happy to do so. My email is jhoffman@ems-safety.com. Be sure to follow me on Twitter, guys. My Twitter address is @EMSSafe. And of course, I'm over on Facebook. It's facebook.com/the EMS Professional. Guys, until next week, Jim Hoffman for EMS Office Hours and the Monday Minutes. And as always, stay safe.